Welcome. Welcome, everyone, to the HSPN monthly webinar, inviting folks from across Ontario, Turtle Island, internationally. Welcome to our webinar this month on understanding equity in the Ontario health system. Please let us know who you are. If you can open the chat box and make sure you type to everyone and not just to host and panelists. I know I make this mistake myself sometimes. And introduce yourself. Let us know where you're joining us from. Looking forward to seeing people as you click in. Diane from North Simcoe, first to the bot. Welcome, Diane. Welcome, Wendy from the OHA. Wendy is a regular attender at our events. Monroe from Great River. Nice to see you, Monroe. And I know that you're also an active participant. Lovely to see you. Nancy from Peel. Sarah from Great River as well. Welcome. Harpreet from, I missed Harpreet where you're from. It's going so quickly. It's hard for me to keep up. We have already almost 150 people online. Danielle from Southern Ontario from VHA. Welcome, Danielle, to join us today. And we have Emily from Port Hope, Donna from West Perry Sound Health Center. Lovely to have you join us. I hope your weather is agreeable up there. I know you got a little bit of extra snow last week, as did we, but ours is gone. So happy to have everybody joining us today. And today we're going to have a really fantastic event, a large lineup, and we have a lot of people speaking today. So as you continue to join in and let people know that you're here and where you're joining us from, I'm going to go ahead and get us started. First, by acknowledging the land, and I'm speaking to you today from the University of Toronto in downtown Toronto, and this is the land for thousands of years has been traditional lands of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And meeting place is still the home to many Indigenous peoples from across Turtle Island. And I am grateful to have the opportunity to work from this land and to learn from our colleagues across all of Ontario, many of you joining us today. We're very, very pleased to hear your thoughts as well as what we have to contribute. We do like to start off with a quick poll to ask you if you have joined us before. So if you could respond into this poll and let us know, have you joined us? Yes, you've participated previously, or no, this is your first time joining. So we will wait and watch while these answers come in. Oh, people are very quick to the punch, over 100 responses, like instantly as I looked across. And here we go. We see people still chiming in. Up over, I think we are getting pretty close to everybody having responded at this point in time. Everybody is engaged today. I'm really pleased to see how engaged people are. And okay, I think we can share this back out. Lovely. So look at that. 53% have joined previously and 47%. This is your first time joining us. Well, I am honored that you are all here and that many of you are experiencing what Health System Performance Network does for the first time. And so you will be able to see all of what we do is also shared up on our website. I invite you to visit hspn.ca and have it stroll around. There's a large section devoted to Ontario health teams. We've been doing a lot of work in that regard. So today, as I said, we are looking at equity in Ontario's health system. We're responding to a number of specific questions that were asked. So this is just samples and snippets, I'd say some snapshots of equity in Ontario health system, both from a very high-level view of the Ontario health system writ large to specific projects that are collecting data and using it for equity. To address equity in their local areas. So I will host this event, provide a little bit of bookends at the beginning and the end, facilitate some of the questions along the way, and I will have the great pleasure of hosting what you see here are a number of the students that are support and learn within the Health System Performance Network. We have a Fellows Caucus, and they undertake projects related to HSPN, and they're undertaking usually theses that are related to these topics as well. One of our past students, Dr. Paul Wanka, is now just this year has moved on to be an assistant professor at McGill, but he's here relative to some of the work he did when he was training as a postdoc with us. So you will hear from Jessica Morgan, Irina Prashaniak, Lale Rashidian, and Xiaoming Ma all the way along through today. And I think that what they have to say, and they're representing other students as well, will be very, very helpful and enlightening. We have the entire team also backing up this work in this field. And actually, I just saw that Grace Spiro also joined us this year as a postdoc. So there are even people, trainees that are not directly attached. I'm going to start off with a quick overview of some of the equity-related webinars that we did in 2023. And then we'll get into the materials that we're going to show here. So first off, for everybody to have known that we held 4 webinars like this. Paul hosted many of them in 2023, starting off with a primer just to what we knew, some of the work that we've been doing around measuring for health equity. Sorry, these slides are going to jump on me a tiny bit here. Then we had a next section on building capacity for equity, moving on to measuring equity, and finally, equity interventions, which was jam-packed with 7 speakers in there for October. I invite you to go back and have a look at some of these webinars. They're all posted on our website along with the presentation materials. You can have a look there. I'm going to give you a snapshot of some of the key highlights throughout these individual ones. So on the right here, you're actually seeing what the distribution of material deprivation is across the 58 OHTs or 57 of the OHTs in Ontario. So up at the top, we have a group that has few people in the area of lowest deprivation and many people. The darkest is the highest quintile of material deprivation. And down at the bottom of the chart, you see other OHTs that have more people that are living in areas with very low deprivation. In fact, even half of the members in the OHT are living in areas of low deprivation. And so we see quite a bit of variability. And so the challenges that are faced by OHTs as they move towards, and these are for people who are less familiar with Ontario Health Teams, these are clusterings of populations in the province of Ontario of between 35,000 and 1 million people, averaging about 250,000 each. So quite a bit of variation. And this can also impact on measures of health outcomes. So we have previously shown that some health outcomes, certainly premature mortality, other things like ambulatory care sensitive conditions, are quite sensitive to these different areas of material deprivation. And even areas of provider and patient experience have some associations. They vary a little bit with sociodemographic factors that are not part of the marginalization index, but also important at the individual level. So there is a fair bit of variation. And these are important then for us to be measuring. In some of the other webinars, we really had ideas that were brought forward. So in the early days, measuring the current state, for example, using anti-Black racism organizational self-assessment surveys, offering one-on-one support to organizations to put in action plans, and building a learning network across organizations and teams. Some of the key lessons from some of those Ontario Health teams that were really working on this space was recognizing equity, diversity, and inclusion as a priority, developing and using a framework for all decision-making within the teams, ensuring the membership and making structures and committees in the OHT being representative of those diverse populations, and then identifying those opportunities to advance diversity and inclusion in every practice and organization within the teams. And we've seen quite a bit of great examples, and you can look back to the webinars to see some of those. When we're talking about interventions, we've really learned that some of the elements of designing and implementing using evidence reviews of affected priority areas, using local case studies to understand what actions have been able to be put in place. So what have organizations and people actually already been able to do, and leveraging those opportunities to spread, to scale those ideas. Engaging with patients and the public to understand patient stories and gauge areas of priority. So understanding from patients what the stories are really in life. And we have an example of what we're trying to do this here, also in be introduced later on Black populations and their access to diabetes care. And then also to get priorities using more community engagement approaches. Measuring these effects quantitatively and qualitatively. I think one of the key pieces that we've learned here, and we'll reiterate this a little bit, is just go. Start somewhere. Engage with the community. You can't engage everybody at the same time, so continuously engage and start working. And that's been a real key lesson for us. And there are some OHTs that have really started that work. And we had a number of examples in the implementations in our October webinar of 2023. So I recommend you go back and have a look at that. From us at the Health System Performance, we do a lot of measurement. And so a couple of the things, all data being presented by socioeconomic status and ethnicity as much as possible where we have it as part of routine reporting. We use the material deprivation as our primary because we have it for the entire population of Ontario. Thinking about indicators that have both short-term, medium-term, and long-term implications, incorporating key metrics into routine performance reports, and generating consensus on equity priorities. So that's work that we're intending to be doing more of in the years to come, working with Ontario health teams from across the province. We do a lot of work integrating the quantitative and qualitative, and you'll see a little bit about that today. Linking data with evidence-based actions as well. So looking out for what's worked in which areas. So that's a little bit of the overview of what we did in some of the webinars for you to go back and have a look at. And there's some highlights also on a webinar highlights page, so you can actually dial in and just see some specific little pieces as well. Thanks for posting that link in the chat. So today we're going to talk about some new work that's been emerging over the past year. A couple of these, most of these questions, they all came from the Ministry of Health, actually. They wanted us to talk about some of the equity reports. And so we have 5 reports that we've worked on. The first is looking at how do we measure health equity for performance reporting, of great interest to us. Another question, are there inequities in the use of virtual care in Ontario, particularly emerging from the pandemic? What are the barriers and facilitators in access to diabetes care for Black and South Asian populations? You may know that we did some reporting in the past year and had diabetes reports went out to all of the Ontario health teams on a number of indicators related to diabetes care, really as a seminal way for us to think about population health management and equity. So this is contributing some data in the background for that material. Most of these are being done at the Ontario-wide population. We haven't narrowed in and stratified by Ontario health teams in these projects. I'll just highlight that. Other work we have often done that. Then we had a couple others. One is around collecting sociodemographic data for community-based action. How do we do that? How do we do that well? And so a bit of a literature evidence review, and then also talking with some teams in Ontario that are advancing their work with this strategy. And then the last question we'll bring up today is some international examples for governance and accountability for equity in integrated care. And for those of you who joined us last month, when we did our international policy review, which we highlighted last month, we also asked this question about how those international examples in England, Germany, the Netherlands, and the United States were looking at governance and accountability for equity. So those results will come today. So as you can see, it's quite a high ambition for us to cover all this material today, and I'm glad you're with us, and I look forward to connecting with you all the way through, and using the chat. And we'll also come down and have lots of opportunities along the way at a few points in time for Q&A. We're going to go through the first 3 topics: measurement, virtual care, and diabetes, and then we'll take a break for more audience engagement and participation. But continue to ask, jump in the chat, ask your questions all the way through. Okay, so to kick us off, we're going to start off with a quick little poll related to our first topic. And our first topic is about measuring equity, and this requires performance indicators and as well as equity stratifications. And so these are ways that we can stratify. And if anybody out there knows all of these, you knew more than I did a year ago. So I was familiar, and we were actually producing indicators on the equity ratio, and we were familiar with some of the others, but actually there's a few in here that I I wasn't aware of myself. So just to get a bit of a gauge on how much you're appreciative of current indicators. So please come in, answer what you know to have been the opportunities here. And hopefully we set this up correctly and you can answer all the ones that you are familiar with along the way. And again, don't feel shy. I expect that the most common, and just having a quick look over here, it looks like the most common answer is the not familiar with any of these, which is hopefully something that we can help you out with today. Yes, Gini coefficient and a marginalization index. Those are other ways of them looking at, and it's actually what we do with the marginalization index is also true. But yes, Gini coefficients are there as well. Lovely. Okay. Wow, we have 200 people online now, and almost everybody has answered in here. Well, certainly more than half the people have answered in here, quite a few. And I would say let's go. And I think we're probably pretty settled in on what the results are now. So what did we learn? We learned that you might have to scroll to get down to the bottom. 73%, this is new material for you. So welcome, and I hope that you'll come out of this with a little bit more awareness. We are very interested in making sure that people understand, and we'll be running more material in the year to come as we do more measurement and reporting on equity. Okay, so without further ado, I'm going to turn it over to Jessica Morgan, who's going to lead us through a little bit on how to measure health equity. Jessica, go ahead.
Thank you. So I worked with Drs. Marissa Bird and Paul Wenka, along with the rest of the HSPN Fellows Caucus, on the question of how to measure health equity. So next slide. So our objective by answering this question was to identify and describe how health inequities can be quantified into a single measure for the purpose of evaluating health system performance. So we tackled this objective by conducting a literature search, which we structured around the definition of health inequity. So health inequities are differences in health that are linked to social, economic, or environmental disadvantage or under-resourcing. When we look at this definition, it reveals that there are 3 necessary components needed to measure health inequity. Next slide. So the first component is the equity stratifier, and these are used to identify different subgroups in the population according to economic, social, or environmental factors. So some examples would be race, ethnicity, sex, or income. The source of data for an equity stratifier would typically be a census or a survey. And the equity stratifier is really what differentiates health equity measurement from measures of average health. It's also important to consider that when you're selecting an equity stratifier, the source and quality and availability of your data. And this is because certain populations may not be represented on certain censuses and surveys. And so you may not actually be capturing what you intend to capture. Next slide. Okay, next slide. So the second component is the health system performance indicator. And these should have directionality, should be comparable, and are used to monitor health system performance. Next slide. The last component is the statistical approach. And these are what are used to quantify the relationship between an equity stratifier and a health system performance indicator. So these are what you were asked about on the poll. And through the review, we identified several approaches in the literature, and we really concentrated on those which were either the most commonly used or the most relevant for measuring health system performance. And the approaches we identified were the rate range, the rate ratio, the slope index of inequality, the absolute gradient index, the relative index of inequality, the concentration index of inequality, and the index of disparity. Next slide. So these measures can be broken down in 2 ways. The first is based on their complexity. So we have simple measures such as the rate range and rate ratio, and then we have our complex measures. Simple measures are most appropriate when the aim is to improve the health of a specific group relative to another, or to serve the starting point for more complex measures. The downside, however, of simple measures is that they can overlook important differences in the population that are present in the intermediate groups. Complex measures, on the other hand, are able to capture inequalities across the entire population, but they do tend to be more difficult to interpret and also are more computationally intensive. So next slide. We also can look at the complex measures in terms of absolute and relative measures. So the absolute measures provide more context than relative measures. So for example, if your HSPI, so your indicator, is rate-based, then they would actually give you the disparity in rate across the population according to the equity stratifier. The problem with them, however, is they are not comparable across different indicators. Relative measures, on the other hand, are dimensionless, so they are comparable across different indicators, but they could lead to an overestimation of the magnitude of health inequalities, especially for indicators that have a low event rate. And they also don't give as much information in general as the absolute measures. Typically, it's recommended that both are reported in order to provide a complete picture of the health inequity problems. Next slide. So the key takeaway is really that there are several approaches you can take in order to measure health inequities, but for all of them, you will need an equity stratifier, a health system performance indicator, and a statistical approach. Your selection of each component needs to be thoroughly considered because it does affect the results and the interpretation of the measure. And your best approach really depends on your aim and what is most important to your aim. So that's all I have for you today. Thank you.
Thanks so much for that overview, Jessica. And Jessica's actually run her whole thesis on this, looking at ambulatory care sensitive conditions as a indicator, and then looking across different approaches and understanding what the effects are of using different approaches to measurement. Good news is that things are consistent across the different approaches, but the interpretations do vary. And so you're going to hear more from us in the year to come so that we can understand which ones are most meaningful to you in your work as at least for the Ontario Health teams that are participating today, which ones are most meaningful to you for your work. And we'll look to do more reporting along those lines. So really, we're trying to do the background homework before we make suggestions on how we do this. Okay, so thanks for that intro. Happy to have other questions come up that you might have. Pop them in the chat and we'll come back around. Next, I'd like to introduce Irina Pashoniak, who's going to show us a little bit about virtual healthcare and equity in Ontario. And we have looking at physician visits for which virtual care is most common. And we have many equity stratifiers. We're going to reduce and just limit it to a few so that we can try not to get too much into the weeds, but we do have reports coming out that will actually have virtual and real care shown across about 8 or 10 different equity stratifiers. So Irina, you go ahead and you can lead us through these materials.
Yes, hi. So I'm here to present virtual healthcare inequity in Ontario on behalf of our larger HSPN team. So next slide. Yeah, so for our project specifically, we were tasked with answering the question of what has been the impact of expanding virtual care for diverse populations. So in order to answer that question, we reached out to ICS to get data on all of the physician appointments that happened in Ontario between April 1st, 2018 to March 31st, 2023. To be eligible, a person would have to be an OHIP holder, except of those with an valid birth date or gender or age over 105 years. And for analysis today, we'll present some of the descriptive statistics of other counts of how many appointments happen per month or per year, as well as rates of use, so that we can sort of compare them from group to group. Next slide. So this is the list of all of the equity stratifiers and variables that we took a look at. So physician visits could be administered in person or virtually for mental or physical concerns, as well as for primary or specialty care. Patients were analyzed based on their age, sex, and Chi-High grouper that allowed us to see the number of physical or mental health conditions that each individual has, as well as immigration status. And for neighborhood variables, we specifically will discuss material deprivation, in this presentation, but as Walter had mentioned, we will have a report coming up with other stratifiers as well. Next slide. To bring us into this topic, here is a slide of total monthly in-person and virtual visits in Ontario from April 2018 to March 2023. As you can see, in April 2020, there's a huge dip and an appearance of this green bar, which is the virtual care. As you can see, we have on average about 19 million appointments per month, physician visits in Ontario per month. That number had dipped for the first couple of months of COVID, by about 46% or so, at which point we had the highest share of appointments administered virtually, up to 35%. And ever since then, the share as well as the actual number of visits have been steadily sort of declining from month to month. Next slide. These are some of the trends of how we use virtual care more. So it's mostly used for primary care as before and after the pandemic, used for both mental and physical concerns, mostly for physical concerns. However, we do see an uprising of mental health appointments every month, administered virtually. Next slide. So who are the patients of virtual care? They are Ontarians. Majority of, not the majority, but a large piece, a large slice of appointments are administered for patients of the age of 65 and above, both virtually and in person. Women are also more frequent users of healthcare and use virtual care more in conjunction with in-person care. Patients with 5 or more health conditions are responsible for more appointments in person and virtual. And as I had mentioned before, as the time goes on, more patients return to in-person care. So our next slide is going to help us visualize the breakdown of total annual healthcare use by age. So these are all of Ontarians registered with OHIP and their use of healthcare. Basically, whether they had in-person visits only in one fiscal year, or had both virtual and in-person visits, or just had virtual visits only in one particular fiscal year, you can see. As you can see, the older population doesn't amount to as many people. However, they do have a higher rate of use, so they do require more appointments per year to sustain their health. The next slide will show us a bit more about sex comparison, male to female. As you can see, we do have more women living in Ontario, and they do use care more. They use care more virtually as well as in conjunction. But as you can see, this little green sliver is diminishing as we go on from year to year, moving away from the pandemic. And our next slide will give us a bit more information about the Chi-Hi popgrouper. Apologies. As you can see, patients who have 5 or more conditions are the heaviest users of healthcare, understandably. And now that we look at equity stratifiers by residency, which is our next slide, we learned that overall individuals in least deprived neighborhoods have a slightly larger population and contribute to more in total visits, both virtual and in person, by the virtue of them just being more people in quintile 1, which is least deprived. But if we look at rates of visits per person per year, then we do find that individuals in neighborhoods with higher deprivation have more in-person visits. Post-pandemic, this is slightly weaker relationship. Now, pre-pandemic individuals in higher deprived neighborhoods had slightly higher virtual care visits per person per year. Post-pandemic, virtual care is now the same across material deprivation groups. And our next slide is going to exemplify the first point that we were making. As you can see, Q1, which is the least deprived quintile of Ontario populations, is just right there on top, but we do have more people within that category. Now, if we look at the following slide, which will show us specific rates of healthcare use by material stratified by material deprivation, then you will see as we move across from Q1 with least deprived to Q5 with most deprived, you can clearly see this sort of a slope up and the need of more appointments. And these are a number of appointments per person per year. Just to clarify exactly what we're looking at here, as you can see, there was some pre-pandemic, just this slight green sliver on the very right at the Q5 before the pandemic. Our Q5 population who was most deprived was using virtual care more than other populations. However, after the pandemic, virtual care had become equally accessible to all all material deprivation sort of neighborhoods of all kinds. And the final couple of takeaways. So the amount of virtual care increased overnight, of course, as we saw COVID-19 pandemic and with all of the restrictions of seeing everybody face to face. Ever since then, virtual care has been declining slowly. Most individuals with virtual care also seek care in person, and we see that trend highlighted even more now that we move away from the pandemic. Individuals with higher deprivation have more in-person visits per person per year. Post-pandemic, this is slightly weaker relationship. And overall, we find that it appears post-pandemic that people in higher deprivation neighborhoods may have lower access to care as compared to those in areas with lower deprivation. So that would be
Great.
all. Thank you.
Thanks for that quick overview, a little bit brief. As we said, we have more stratifiers and we've done more work in the background, trying to give a little bit of a high level touch point on some of these pieces. And it is indicative, though, that we see areas with higher deprivation having greater health needs. And we know that there's more chronic disease burden, for example, in those populations. And we do see more care in total for those individuals. But it does seem that over the past number of years, as virtual care has increased overall, that perhaps some of those people in the areas of highest deprivation have lost some of their advantage. So, according to their health status, if we were to make more adjustments, we might be a little concerned that there is a reduced access in that population. So definitely something we really need to keep an eye on. It is good to see that virtual care currently is being equally distributed across material deprivation, but that doesn't mean that it's being equitably distributed across the different areas of material deprivation. We might prefer to see more care, both virtual and in person, in those areas of higher material deprivation. So we're going to keep a close eye in and dive into this and continue to delve in a little bit more as we move ahead. It's important for us to look at this to make sure that we are meeting the needs of those people in population in Ontario. So just giving a little bit about that, here's a question for you in your OHT or your area or geography. Do you expect virtual care for physician services, this is the glass ball, in the future to increase or decrease? So do you expect it will increase or decline in the future as we continue to go, or perhaps you expect it to stabilize and stay about how it is now? Very interested to see what people's perspectives are on what the future is for virtual. And I'm asking about physician services because that's what we've been looking at, and it's what we can most easily keep our eye on. So I'm interested to hear, what do people think? And I think, think about what we ourselves might want as we encounter in the health system, as well as those we serve. Great. Why don't we share up this result, people, and let's see. Oh, okay. Well, so a slight advantage to those seeing. I expect it will increase 47%. Many people right behind there expecting it will stabilize and stay about how it is now. And then some people thinking it might still decline a little bit. But it's interesting that there's still a perception that physician services will continue to be virtual and increase. One more poll for you. And here's what do you perceive and what do you think? And I see some chat, and I think that it's going to be interesting when I get a chance to look over the chat a little bit more carefully here. Do you believe that virtual care is reducing inequities in access to healthcare? Is it helping us? Yes, it's reducing inequity. That would be helpful. Partly, no, there's no effect. No, it's not reducing. And in fact, it may be making things worse. So be very interested to think about what you have to say about this. And again, we have lots of the people reporting in, very quick to the punch. People are very familiar with answering these now. Lovely. Okay, could we share out this result and see what people have said here? Well, 17% say yes, it's a good thing. It's reducing inequities. 56% say partly, not always. And we could get into quite a discussion. I'd be interested to hear in the chat about where it might be and where it might not be. because I think I did see, some people, unhoused people having access to virtual care if they don't have internet, cell phones, some of these things, there can definitely be barriers. Some people thinking perhaps it's making inequities worse, 20%. And we've seen some data here that in the overall visits, inequity appears to have gotten a little bit worse over time in terms of access to physician care in the province. Multifaceted reasons for that, perhaps, but and more look at how that looks when we consider around the inequity. So, Irina, I know you had this slide. I put in this the polls ahead of your closing slide, so I'll just cover this. That just notes that there are some data limitations and a complex interaction between different stratifications that we can be looking at. So I'm going to have a look over at the chat while Lale talks about some of our work looking at access to diabetes care, particularly for South Asian and Black populations. So starting to take a little bit of a look at race and ethnicity in our work. Lale.
Thank you, Walter. I'm very happy to be here. Hope the audio is working okay. And I'm delighted to have the opportunity to represent our team in looking at access to care, access to diabetes care amongst racial subgroups of the population. Next slide, please. So the research question that we were provided by the ministry was, what are the barriers and facilitators in accessing diabetes care for South Asian and Black populations living in Ontario? And we decided to break this down into two components. So these two components, the first one uses quantitative data methods, so looking at like the ICS databases, and it measures diabetes access to care and outcomes across South Asian populations in Ontario. The second component will be using more qualitative data methods like interviews, etc., to explore the barriers and facilitators that are impacting diabetes care across Black populations in Ontario. Next slide, please. So here I'm going to go into a bit of a deep dive on the first component, so the quantitative data relating to South Asian populations in Ontario. And so the target population that we were looking at was South Asian populations that were included in the Ontario Diabetes Database. So in order to be in the Ontario Diabetes Database, these patients needed to be covered by OHIP. They needed to have either type 1 or type 2 diabetes. So this did not include individuals with gestational diabetes. And just to be included in the database in general, individuals need to have either one hospital discharge related to diabetes or 2 physician service claims related to diabetes within the past 2 years. Now, this is all diabetes patients across Ontario. So in order to separate the South Asian individuals from these, we use something called a surname algorithm, which was developed in 2010. And basically what this is a list of surnames that are common among the South Asian population, but they are not common among other ethnic groups. And this has been found to have very high specificity, so over 90% specificity. But since it doesn't include those surnames that are included among other ethnic groups, the sensitivity is lower. And our sources of data for this were administrative data through ICS, and I've listed the databases here. In general, these look at, these help us to see healthcare utilization as well as hospital data, and also data on medications use. And we will be looking at 5 specific indicators, which you can see in the blue rectangle on the right. For those of you who are familiar with the HSBN diabetes report, these are the similar indicators to what we use in that report. So we have the top 3 indicators, indicators 1 through 3, are related to diabetes access to care and diabetes management. So we have the proportion of patients that are up to date on their HbA1c screening, the proportion of patients that are up to date on their retinal screening, and the proportion of patients with diabetes over the age of 65 that have had statins dispensed within the past year. So indicators 4 and 5, these are outcome indicators related to adverse outcomes for diabetes, and they look at hospitalization for long-term diabetes-related complications, and finally, the proportion of patients with diabetes that have poor glycemic control. Next slide, please. So first of all, what we're going to do is we're going to look at data across 3 years, so from 2019 to 2022, which is the most recent year of available data. And we're going to look at trends in the data and compare this among the South Asian subgroup to the Ontario average as a whole. So on this slide, we have the 3 indicators related to diabetes access and management. So on the left, we have HbA1c screening. In the middle, we have retinal screening. And on the right, we have the statins dispensed. So just looking at the slide, you can see that the pattern, the changes in the data are similar among the South Asian subgroup compared to Ontario as a whole. So for HbA1c screening on the left, we can see that in 2020, which is the blue, there was a significant drop in patients that had HbA1c screening compared to the previous year. And in 2021, this recovered somewhat, but was not yet at the level that it was prior to the pandemic. Looking at retinal screening, we can see that again, both across South Asians and Ontario as a whole, in 2020, this dropped compared to the previous year, and this continued to drop in 2021 and 2022. And with statins on the right, we can see that this remained relatively stable across both the South Asian subgroup and Ontario as a whole. Next slide, please. And on this slide, we have our two indicators related to adverse diabetes outcomes. So on the left, we have the proportion of patients that had poor glycemic control, so high HbA1c levels. And again, we can see similar patterns in the data. So the proportion of patients dropped in 2020. However, this is due to missing data, since the proportion of patients that had HbA1c screening also dropped. This recovered somewhat in 2021. And with hospitalization, we can see there was very little change in the data, a slight drop in 2020 compared to the previous year, but again, not a huge change here. Next slide, please. So in the next part, what I'm going to do is I'm going to look at each one of these 5 indicators across our 5 quintiles of material deprivation. We're going to compare this among the South Asian subgroup and Ontario as a whole. So this is based on the most recent year of data, so 2021-2022. The light green represents the Ontario average and the orange represents the South Asian subgroups. So this is for HbA1c screening. So we want higher screening rates, so higher rates are more desirable. And as you can see here, across quintiles 1 through 4, the proportion of patients that had HbA1c screening was lower among South Asians compared to the Ontario population. When we look at the quintile 5, which is the quintile with the greatest material deprivation, we can see that among this subgroup, South Asian population were more likely to have their HbA1c screened compared to the Ontario average. Now, looking for just a gradient in socioeconomic status, so we would expect, if there were inequities in the system, we would expect to see that screening rates were higher among Q1 and kept going lower as we go through Q5, but we don't really see an observable gradient here just based on this data. Next slide, please. So this, again, we're looking at all of the indicators in a similar way. So light green is Ontario, higher, again, is more desirable. So we can see across quintiles 1 through 4, the orange bar is lower. So South Asian subgroups were less likely to get their retinal screening done. And when we reach the most deprived quintile of the population, so Q5, we can see that we have similar rates of retinal screening among South Asians and also compared to the Ontario average. No socioeconomic status. So again, we would expect higher rates among Q1 if we had inequities in the system, but there seems to be, at least among South Asian subgroup, no discernible gradient that we can observe. Next slide, please. So these are the proportion of patients over 65 with diabetes that had statins dispensed in the past year, and this helps in the prevention of diabetes complications such as macrovascular, etc. So here, again, higher is more desirable. And we can see, surprisingly, so this is not similar to what we saw in the previous 2 slides, that among South Asians across all 5 quintiles of material deprivation, individuals were more likely to have statins dispensed compared to the Ontario average. And here we see almost a reverse socioeconomic status. So we have a gradient here. So among quintile 5 patients, South Asians were more likely to get statins dispensed compared to the Q1, which is the least deprived quintile of the population. Next slide, please. So now we're moving on to our 2 indicators related to diabetes outcomes, so adverse diabetes outcomes. So here, lower is more desirable. So we're looking at patients with poor glycemic control. So we're seeing across all 5 of our quintiles of material deprivation, South Asians were more likely to have poor glycemic control compared to the Ontario average. And here we do see a slight sort of breaking here as we see that as people become more deprived, as we move from Q1 towards Q5, people are more likely to have poor glycemic control. Next slide, please. And related to hospitalization for long-term diabetes-related complications, again, lower rates are more desirable here. And we can see that This is again surprising. So we can see that across Q1 to Q5, South Asian populations, even though they were more likely to be in poor control, we are seeing lower rates of hospitalization across all 5 quintiles of material deprivation compared to the Ontario average. And we do see a slight socioeconomic status gradient here. So we can see that individuals who had the greatest material deprivation in Q5, they were more likely to be hospitalized for a complication compared to those who were less deprived. Next slide, please. So we talked about all 5 of our indicators comparing South Asian averages to that of the Ontario population as a whole. On this slide, what we're going to do is we're going to look among South Asian subgroups, separating them into immigrants and non-immigrants based on data collected from the IRCC. So non-immigrants also includes people who immigrated prior to 1985, and those who fall into the category immigrants are listed in the bubble on the right. So the orange here is South Asians who are immigrants, and the light green is non-immigrant South Asians. And looking at the 3 on the left, so these were our 3 diabetes access indicators, we can see that immigrants were less likely to have their HbA1c screened, less likely to have their retinal screening, and also less likely to have statins dispensed. Looking at our 2 indicators on the right, these were our adverse outcome indicators. I don't know if you can see here, but immigrants were more likely to have high HbA1c levels. And again, here we see that hospitalization it's very small, I know, but hospitalizations were less common among immigrants compared to non-immigrants, which doesn't, it's a surprising finding. It doesn't align with the direction that we're seeing the rest of the data taking. Next slide, please. So overall, what we saw was that access to screening services, this includes HbA1c screening, retinal screening, was lower across South Asian populations compared to the provincial average. However, the South Asian populations living in Ontario had higher rates of statins dispensed across all quintiles of material deprivation. And even though patients were more likely to be in poor control of diabetes across South Asian populations, we saw a surprising finding, and that was hospitalization rates as a result of long-term diabetes-related complications were lower than the provincial average. Next slide, please. So I talked quite a bit about the first component of our research, which was related to the South Asian populations. Now I'm just going to go like a couple minutes about this second component, and this is ongoing. So it's going to explore racial barriers and facilitators to accessing diabetes care in Ontario for Black populations. So we are in the stage of conducting interviews for this, and we are very interested to get this out there. We know that we have people from all across Ontario joining us today from different parts of the healthcare system. And so if you feel that this is relevant to your target population, if you have programs, you think people would be interested in this, we invite you to jot down the contact information listed on the slide. I will also put it in the chat in a minute now, and just reach out to us. We'd really appreciate it. So what we will be doing is we will be identifying challenges that exist in accessing diabetes care for Black populations in Ontario. We will be collecting data via one-on-one interviews. So this can be done based on using telephone, Zoom, or in person based on individual preference. And interviews will last approximately 30 minutes. Anyone over the age of 18 who identifies as Black, has diabetes, and lives in Ontario is eligible to participate, and individuals will, of course, be compensated for their time with a gift card for participating in the interview. Thank you so much, and we look forward to hearing from you.
Thanks very much, Lale, and don't go way too far. And I think there are a couple of questions that have come up in the chat. Interesting and I want to leave this up on the screen so that people can also catch it, because we in this area, finding individuals at the right time and reaching out to Black populations who are seeking care for diabetes care it's an important area, but it's an area where we're continuing to recruit. We've only had a few people that have participated so far, and we're hoping to get more people and a larger view. And also, we've been recruiting mostly locally in the Toronto area, and I'd really like to have the opportunity here. We know we have a provincial forum, so we're taking advantage of this. And you can email Lale directly or email HSPN, and you will be put in contact with the research team from anywhere, and they'll reach out with any of the recruitment materials that we have available for doing this. There was a question, a very sort of simple question around how long are we recruiting for? I think we'll be recruiting well into the end of April at this point in time, given how many we have. I think so. it's worthwhile, you're continuing to do this. I would hope probably by the end of April, we should have enough people, especially if venues like this are helpful. Look forward to it. And I appreciate, and the contact information has also been provided. And thanks for the ideas on specific additional groups for us to be reaching out to. There was a little question about how we chose for the gift card. I think we leave it up to the choice. We've got a menu of gift cards and people choose, right? I think that's usually what we do. There's a question, though, around how South Asian was defined. And as I recall, and I'm hoping you remember, there are some groups that are more specifically included in the surname database.
That's correct. And I can put it in the chat. I'll put it in the chat for anyone who's interested.
Yeah, well, you can also just speak it.
Yeah, basically, so it's Southeast Asian population, so specifically. So and it's I'm gonna have to put up the paper and just send make sure I don't get anything wrong, just to make sure it's accurate exactly. But I'll put it in the chat for anyone interested.
Certainly, there are some nationalities, I think, where it is more specific than others, where the last names are more specific, and so that is how we've done it. And so Lale will put the paper in the chat that was led by Baju Shah at ICES a number of years ago. So I think also I'll just let people know there's been a little bit of chat. We don't do a great job at including data from community health centers. And your data lead on community health centers, Jen Rayner, is constantly at me for this. These are projects where we could do better because they're not some of the standardized reporting. Even in the standardized reporting, we're hoping to work with Ontario Health to end up with indicators that are inclusive of the CHC data, and also in the attributable populations, there's work underway to do better in that front, particularly in regard that CHCs are very often specifically targeting areas of equity. And so I just want to acknowledge that and efforts that we will undertake in the year to come on things like even our diabetes indicators, when we put out our reports last year, did not include CHC delivered care, like care delivered in CHCs. They definitely included people who got their care in CHCs, like the people, but often actually we are ending up underreporting some of their care because it was delivered in CHCs. So reporting is improving, we are improving, and particularly I think in this area of equity and social determinants, we will continue to do more and better. On some of the previous, there was work related to integrating virtual care into the system. Some people were indicating and noting the equity issues as they relate to rurality, internet service in particular. And then Monroe had written in saying the measure of virtual care in the province of Ontario includes telephone because it's not in person. And so our indicators do include telephone care as well. And actually, it's difficult for us to distinguish. There are some billing codes for video versus phone that we're now starting to be able to make this distinction. But at the time that most of this was done, we can't distinguish whether these were telephone or video. Now with the new billing codes for physicians, we're starting to be able to do that. So that may also be a difference, and that may also affect how we report. So I'm actually going to drop the slides for a second, I think. Oops. Yeah. And just see if there's more chat around that we can talk about. So I'm very interested in some of these other conversations that we have, and engaging with participants. So, Brian is talking about another equity about people experiencing homelessness, and have we looked at this population? And now there is mandatory reporting, and I've seen some studies start to report this out, and I think it's also a very important group looking at different hospitalization and follow-up care amongst these people that, yes, now being collected. And I hope we haven't looked at the data quality, but I do know that in the downtown Toronto, some of the hospitals have done a very active role, and there is mandatory reporting of this. And as I understand it, and hear about it on the news, that homelessness is not an issue that is specific to downtown Toronto, that it is very much being experienced in many, many communities across the province of Ontario. And so we haven't done that yet, but I do think, and so other ideas that you have for important populations for us to be thinking about and looking at in equity, because we really think that, part of what we're really trying to do here in Ontario, across Canada, and globally, if we look at health systems, is one, moving to a quadruple aim and a quintuple aim framework for measuring impacts to the health system. So very much that patient experience, provider experience, health outcomes, and cost, and in every case, looking at it through a lens of an equity approach. So looking at all of these tools through an equity lens. And the other thing is advancing towards that through the approach of population health management and equity. And we can't actually get to population health without thinking about equity, because we really need to both improve the health of the population, but also particularly to be concerned about the tail ends of the population, people who are not. There's a question from Anne-Marie: is the data by age group incorporated into all the data? Well, we did see in Arena's presentations around the virtual visits, actually, she presented up some of the data by age and sex. I can't remember, Lale, I don't know if your work has specifically addressed. I don't think we presented it today.
No, we haven't, not today, but we do have that data available.
Is it in the report that will be produced?
It isn't, but we can add it. We can do an addendum if there's an interest in that.
Yeah. Okay. Well, we seem to have a question here. So certainly if the sample size permits, I think we could look at some, because there may actually be different sex and age. And, one of the things we've had a consideration of is with the immigration status, which this is the first time we've used that field, actually, is to look at the immigration status. We want to do more with that. And there's also a duration of immigration, how long people have been in. And I know that Immigration and Refugees Citizenship Canada, that gives us permission to use that data, are also very interested in actually also the different forms of some of the immigrants and the refugees and the status in which they're being brought in. So I'd be interested in knowing from you if you have other targets, other areas that you are working in as they relate to equity projects. Are there particular populations that you've been focused on? Are there others? And I also have this other question going back to the virtual care about whether you are familiar with physicians in your area and how to decide whether to deliver care virtually or not. And I know that there was a question, I think it was by Natasha, asking about, or mentioning about this notion of when virtual care might be best and might actually be preferable over in-person care. And I don't know how that is decided. If the OHT has any initiatives, because I do know OHTs are supporting a lot of virtual care through digital initiatives, and how that's being thought about. And I think we need to understand and know more about that as well. And also there can be images or questions related to accessing virtual care for digital. Yeah, there's a good question in the chat. So I ask for people to kind of bring this up, keep the chat active around other people who are participating today using, for example, the OH measuring health equity data to inform the programs and planning. And I do know that in the e-report portal, OH is starting to allow or provide more data as it relates to material deprivation, certainly as being one of the lenses on which people can look at some indicators. Yeah, there's a question. People being focused on the unhoused population, virtual care is not a solution for them. And so no phone booths. There are no phone booths. Being concerned about the impact and cost with unhoused visits to hospitals. That's a great question. Please keep these questions coming, as well as the points of intersection with others on the line today. It's a great opportunity for us to learn and share about what others are doing as it relates to marginalized populations. And, as I remember our colleagues down in Hamilton, gather some data, but don't wait till you know everything. When you know some things, start to act. So I think that's a great opportunity. And so let's keep up this sharing happening today. And so I'm going to come back now. If I can get to the right screen, I am going to come back now to sharing out the couple other pieces of work that we've been doing. And so I'd like to welcome Xiaomeng Ma to come join us today and talk about that project and other projects related to collecting community-based sociodemographic and equity data and using it to drive action in the community. So welcome, Xiaomeng. Go ahead.
Thank you, Walter. Hi, everyone. This is Xiaomeng. Thank you for having me. I'm glad to present this work today on behalf of my fellow team. This work addressed the question of how do we collect and use social demographic data to support community-based health interventions. We identified 6 social demographic data collection tools and shared 2 examples on assessing the well-being and health needs of community. I'll also go over a case study on the Greater Hamilton Health Network, OHT. The Greater Hamilton Health Network shared their important experience with us on collecting social data from healthcare seekers and people living in residential care facilities. Next slide, please. So social demographic data is important for targeting health interventions, but it is not adequately recorded in our system. The benefit of collecting social demographic data is multifaceted for patients, health organizations, providers, and payers, including strengthening the patient care team member relationship, planning and tailoring services, and empowering health organizations to advocate for new policies. Next slide, please. In addition to social data, community health need and well-being data should not be overlooked because it furthers our understanding on the community we serve. This portion of data can help to assess the current practice against the healthcare models and collect evidence demonstrate the impact of our community work. These 2 domains of data better prepared healthcare workers to take actions that help community residents, especially those are marginalized, to realize evidence-based decision-making in collaboration with the community. Next slide, please. So for social demographic data collection tools, we found 4 Canadian questionnaires and US-based questionnaires from our research. These social data collection tools were determined based on first, the feasibility of gathering information from responders, and second, whether these tools' design was intended to support health intervention work. These collection tools that were shared today have been empirically validated in the real-world scenarios. For the US-based questionnaires, the prepared questionnaire is an important one. It contains 21 social determinants of health domains that have been paired with an implementation and the action toolkit. These 2 try to address the social data standardization issue faced by organizations. The collected data can be standardized across ICD, the disease diagnostic codes, and other controlled medical vocabularies, which means that this social demographic data can be entered into the existing EHR systems without any adaptation. For Canadian-based questionnaires, 3 Canadian-based questionnaires shared a similar design, which I'm referring to the Social Demographic Data Collection Survey, the Measuring Health Equity Demographic Data Collection Survey, and the Toronto Public Health Equity Data Collection Survey. They include the questions that link to issues significantly impact the patient and the client health outcomes. The questions always ask for information on language, birthplace, race or ethnicity, gender or sex, sexual orientation, disability, income, and income support. The upstream lab particularly ask for information of housing status, which also makes great sense because housing is taken as an important consideration among all social determinants of health. Next slide, please. The last Canadian-based questionnaire was designed by the Greater Hamilton Health Network in collaboration with experts from the McMaster. Compared to the 3 previous questionnaires, it has emphasized more on collecting data on indigenous identity of individual, whether the individual has a health card, having a family physician, and what is the employment status and house type of the individual. For more details on accessing the specific questionnaires, the use case of each questionnaires and the particular survey items, you can refer to our full report, and which will be online soon. Next slide, please. Assessing community well-being and the need for healthcare involves evaluating the overall health and the quality of life of a specific community or a population. And as the process helps to identify health-related challenges and determines the necessary health services and the interventions required to address. Based on the evaluation examples from the Access Aliens and the University of Waterloo on their regional community, questions are suggested to ask for assessing a community need and well-being always include: first is their self-rated physical and self-rated mental health, the length of time they spend living in that community, the number of relatives and close friends, sense of belonging, sense of trust, and their feeling about inclusion and discrimination. For conducting such an assessment, we encourage OHT to start from first forming a steering committee and then define the community you will assess, identify assessment objectives, identify principles concerning diversity, develop a comprehensive work plan, and engage the community in reviewing your findings. Next slide, please. Finally, last but not least, when we last year interviewed the Greater Hamilton Health Network for their experience of interacting with deprived communities and gather data from them to design customized healthcare services. First, it was shocked for us to find that the high deprivation rate and the big difference in life expectancy and the poor healthcare access of those who live in the residential care facilities in the Greater Hamilton area. To improve the situation, the Greater Hamilton Health Network, OHT, has introduced a race-based and social data collection into various projects they developed, like a lower limb program and the Women Health Days. Next slide, please. From their experience of tailoring services to serve the community, we found the most important step first is always to building trust with your client. And then following that is listening to their needs, addressing their instant healthcare issues, providing them with social support, and then try to link them to primary care physicians to establish a long-term healthcare pathway. And it was also more easier to start from grassroots rather than start from big organizations based on their experience. Data integration is a big challenge they faced. Having partners coming together with a shared objective, a unified platform, and the common set of questions was crucial to standardize the information and also to prevent its misuse against the vulnerable population. Other than this, aligning goals with partners and building trust among stakeholders are critical topics we identified from this case study. And also, these are long-term goals to achieve the sustainability of an intervention program. Yeah, so that's all what I want to cover for today. And thank you so much for your attention. Hope you'll find it something useful for your work. Thank you so much.
Lovely. Thank you very much, Xiaomeng. And yes, so we really think that when we look at our health administrative data, which we have for the entire province of Ontario, it is very limited in how we can understand individual level sociodemographic, socioeconomic, and equity related information. And so Xiaomeng and the team have really done a great job at having looked at what other people are doing, what are some of the best practices in this area. So we think this resource will be very valuable to a number of the Ontario Health teams, and some of them who we were talking with along the way have already reached out to use some of them. And I just have to say, so many things, like just things I'm not often or usually thinking about, have really come back. And then some notions around even things like household violence and safety being really important determinants and things that we really need to think about. to enable health and wellness amongst our communities, amongst the people. So as we're thinking about equity, we have to have very wide open eyes and be looking in many, many different ways. And I think that's been some of the work here. So also really look forward to people being able to make use of these and collecting them and using them to inform your work within your OHTs and other activities. Thanks, Xiaoming. The last presentation we're going to have today, we've really covered, I told you it was going to be a bit of a whirlwind tour, lots of different aspects. I think it's been a really dynamic team, is to take a step back and think about what are some of the core enablers for advancing equity into integrated health systems. And joining us today for this is Dr. Paul Wanka, who has been working along with the North American Observatory team in ensuring that we are gathering this information everywhere we look. From a policy perspective, what are some of the enablers? From an organizational leadership and governance perspective, what are the things that we can do to ensure and advance equity in the integrated care system? So, Paul, I think you'll be joining us here.
Yes, thanks, Walter. And hi, everyone. It's always a pleasure coming back to present here in our equity webinars. So following the equity webinar that Walter and I co-hosted last year, the next logical step was to understand how equity in health and healthcare is incorporated and routinized within real-life integrated care systems. So next slide. So specifically, we reflected on the research question: what are international examples of governance and accountability for equity in integrated care? So this question was explored using during an international case study that was presented in last month's webinar in collaboration with colleagues from the North American Observatory on Health Systems and Policies. And I would say overall, we found out that equity in health is often explicitly expressed as a policy priority in integrated care systems and models around the world. However, what this means in terms of providing services to disadvantaged groups, or the way the organizations distribute resources that meet the needs of the disadvantaged groups, really differs. Next slide. So our international case study of England, the Netherlands, and Germany showed that there were great variability of equity promoting initiatives, both between the countries and even within the integrated care programs that's in the different countries. So in England, we noticed that various integrated care systems focused on different priority populations. So for instance, some of them actually focus on organizing and improving care for frail, socially isolated older adults. And these were mostly like in the rural and the remote areas. And while other integrated care systems, they focused on improving care for, racialized groups in the socially deprived urban areas. In the Netherlands, we found that there was heightened capacity for monitoring and planning at the local level. So this was a lever to advance their equity work. However, models like the neighborhood care teams, they planned and rolled out different kinds of equity promoting interventions. For example, the neighborhood care teams in The Hague focus on investing in support for socially and materially deprived neighborhoods. Now, for multiple integrated care models in Germany also leverage monitoring and planning at the local level to advance their equity work. And one such example is the Hamburg Health Kiosk that carried out cultural adaptation of their healthcare workforce by investing in care providers that could easily communicate with their local population that face linguistic barriers to care. And next slide. So our learnings from this international case study, so the four main lessons that we could summarize was that successful equity promoting activities were most often related to local initiatives that decided to engage in actions to improve care for their local populations. This speaks to important elements of change, such as visionary and proactive leadership, as well as building capacities for equity work. So we also noticed that although these countries we studied had different priority target groups for equity work, a transversal pattern of three main groups emerge from our data. That is namely the socially and economically deprived individuals or neighborhoods, the old frail adults, mostly living in rural and remote areas. And also we noticed that Black indigenous populations of color, these communities, and recent immigrants were also a target for most of the equity promoting activities. So access of data for evaluation and monitoring planning at the local level was critical to developing and implementing equity promoting initiatives. And finally, we did not find any system level examples where equity was incorporated within the governance and accountability frameworks. So although this system level governance can actually set priorities, which can lead to the reflections for equity and healthcare work. But at the operational levels, equity promoting initiatives still lack accountability. And this is an area for more research and how we can actually promote these practices. So thank you for that.
Great, thanks. Super brief overview, Paul, and it has been a challenge, I think, for others to have set this as a priority. And sometimes in some countries, it's actually fairly sensitive. Some are more bold about taking it on than others. In Germany, for example, it is a politically sensitive topic, whereas in the United Kingdom, England, they are much more open, I think, about trying to address inequities and social determinants and build more. And yet still, and they have a lot of data supporting work. We've learned a lot from them. If you were to go back to our June webinar last year about how they're supporting localities with some of their equity measurement, and then also some of the interventions. We had Sarah Sowden talk about some of those in the fall in October, really activating towards areas of material deprivation, and social deprivation is one of their focus areas for all of their recovery efforts. Look to see more discussion here. I'm interested in perspectives in Ontario. Do you have a sense of some of the opportunities participating today for Ontario health teams to address equity through governance and accountability mechanisms? We see a lot of work at the front lines, close to the community. And I think that is where the work has to happen, but also to see it set as a priority. So I believe it was in May last year where we had a couple of the OHTs on, I believe it was Mississauga and West Toronto. Paul, you would know best if I got the right ones, around their anti-Black racism initiatives and really building up the capacity, the awareness within their organizations of what this meant. Building up cultural sensitivity. I saw some other people, I think it was Tariq, talking about even building up sensitivity in their neighborhoods around people of Mennonite backgrounds and culture. So I think it's always important to be understanding and being made aware and self-reflective and reflexive in our work when we're working with communities. So I'm very interested to know if people have some thoughts on this question here about opportunities that there might be for Ontario health teams to address equity through governance and accountability mechanisms. Are there things and ideas that might be talked about? A couple of people are asking about community health ambassadors and the options. I think it's a good avenue of being able to collect data. And I did look. There was work supported by the Ontario Ministry of Health immediately during the pandemic around some of using the communities that had high infection rates to reach out and then to improve vaccination rates amongst those groups and communities, and then later turning more to chronic disease measurement. And we're actually going to be having a little bit of a look at that program in collaboration with the ministry and some of the programs in the coming year. There is also work at Health Commons Solutions, who we've partnered on in the past with some of their communications materials. And they have, I think, also put some more information together and packages and materials about community health ambassadors in that group. So I might recommend checking out the Health Commons Solutions group. They've also done some work, and we'll have more in the year to come around the value. I don't see new comments on here, so I just want to come back and close out with a couple of comments now and thoughts. We want to be self-reflexive too. So at the end of the day, you know, we've done a little bit of this work. We're starting to have this conversation. We've had a number of conversations over the past year. So will it make a difference? So one of the things that the Health System Performance Network does is produce indicators. And we do this quite widely, and we share them quite widely across Ontario health teams. We're out in the field. We just shared reports out with all of you, and we are the Ontario health teams, and we're out now having engagements and encounters with the teams to talk about that data. In the month to come, we've done some stratified analyses, but as you might have caught on from the first presentation from Jessica, and actually I've stolen a slide off Jessica's thesis of things to come in Ontario. So here is something I'm just going to share with you now of the way you might start to see us showing up our indicators. So we do lots of times things like, what is the ambulatory care sensitive hospitalization rate? We have ED visits. We have many other indicators for each Ontario health team. So these are actually data from Ontario health teams across the province. And what you see across the bottom are the ambulatory care sensitive hospitalization rates. These are usually produced per 100,000 population. So you see the median there, about 238, but some OHTs being down in the kind of like 200 range or less than 200. Meanwhile, there are others up at the, well past 400, 450 range. So quite a bit of variability. And then we also look to see if this is related to inequities within the OHT. So places that are completely equitable, so there's no difference at all between the highest and lowest areas of marginal deprivation. They'd be down on that 0 line. And then as you see, we get up. We have much higher rates where the differences can be much larger. And so we actually see a strong, in this indicator, positive relationship that where we see higher rates of ACSC hospitalizations, we also see higher rates of inequity, meaning they are driven by those areas with greater marginal deprivation or people living in those areas of marginal deprivation. So you're going to start to see this. Get ready for a new form of reporting indicators and equity across our work. Couple other things coming up, just like everybody to know. We run this webinar series for almost half of you, which was like over 100 people today. This is your first time joining. Well, watch them. Hopefully we have other topics of interest to you in the future. We are here every month, the fourth Tuesday of the month from 12 to 1:30. And a little bit of a look of what's coming ahead for the next year is we're going to run a little bit of a series on when we do lots of work on measurement and equity. So a little bit of some of the mechanisms for ways to start to advance towards population health and equity. And we're going to run a little series on something called learning health systems. So for those of you who are aware of learning health systems, hopefully we can provide some valuable content. For those of you who aren't, here's a little primer that you can go and have a look at. This is work that was, we also received support from the Ontario SPORE Support Unit, and this work was supported by the Ontario SPORE Support Unit around an action framework for learning health systems. And you see on the right side of this diagram is a quadruple aim approach. So affordability, experience, sustainability, population health and quality, and equity. So those are the goals, and this is the mechanisms and the approach, starting with data, deep in patient caregiver co-design, using evidence, thinking very carefully about implementation, and then evaluation and feedback and adaptation and pivoting. So these are all topics we think about and talk about. We're gonna in the coming months come in and unpack this a little bit, and hopefully we can have some help from our friends over at RISE. You'll see this through their materials, Learning Health System, and also our colleagues at the Trillium Health Partners Institute for Better Health to help us out with this piece. So that's coming up. Don't miss. I think lots of learning opportunities for all of us. This is the big bold slide of sharing some feedback today. You've seen a little bit in the chat. Really, really appreciate your joining us today. And all of this material will be posted to our website in about a week, where you can also catch past webinars and presentations. Thank everybody. Thank you all for joining us today. And any other comments you have or questions or suggestions, I hope it's been useful. We thank you for joining us, and I hope that you have a lovely Tuesday afternoon through the rest of your days, wherever you may be. Thank you.